Hello, and you're very welcome to this BTOG webcast. My name is Professor Neal Navani, and I'm a consultant respiratory physician at University College London Hospital and a member of the BTOG steering committee. This is part of our regular webcast and podcast series entitled BTOG Does. It's important to say that sponsors of BTOG do not have any role whatsoever in the planning, content, or delivery of anything we're going to discuss today. So today's webcast is BTOG Does TNM9, and it's a great pleasure to introduce Dr. Tanya Patrick. Tanya is a clinical research fellow and respiratory registrar at University College London and is one of the trainee representatives on the BTOG steering committee. So let's dive into TNM9 for lung cancer staging. As we know, TNM9 was officially approved by the UICC in January 2026 and is now being implemented in our lung cancer multidisciplinary team meetings. So Tanya, maybe we can start by just asking you to give us a bit of background to TNM9 and how it was developed.
Yeah, absolutely. Thanks, Neil. So the International Association for the Study of Lung Cancer have an international staging project, and this runs in phases. The TNM 9th edition is part of the third phase of this project, and it includes patients diagnosed with lung cancer between the years of 2011 and 2019. This data has been collected from across the world, 25 countries, 75 sites, and over 100,000 patients. This then gets whittled down when we think about data completeness to about 87,000 patients with lung cancer. Most of those, about 70,000, have non-small cell lung cancer, about 5,000 have small cell lung cancer, and the other histology forms about 8,000 cases. If we then think about geographical distribution of this data set, which I think is quite interesting, then there's been a change in this edition compared to the previous edition. In this edition, we have 56% of data being contributed by Asia and Australia. And Japan alone contributes about 20% of data just by itself. The second largest contributor is then Europe, which used to be the largest contributor, and then North America, South America, more than it used to contribute in South and Central America, but still only 3%. And newly contributing, we have Africa and the Middle East. And then this huge data set is analyzed to see if changes to TNM stage are required to improve our description of the anatomical extent of lung cancer.
Thanks, Tanya. So a huge amount of work that's gone into developing the TNM9 data set. Perhaps we can just summarize some of the key take-home messages before we dive into some of the details.
Yes, so starting with our T or tumor classification, the reassuring and good news is that we don't have significant changes here. In fact, there have only been some useful clarifications in these descriptors, which we'll go into. One of the key changes is the N categorization. N2 has now been subdivided into N2A and N2B. N2A is if you have single station N2 disease, and N2B if you have multi-station N2 disease. And there's been an associated overall stage change. The M categorization has also changed. So now we have M1C, which is where you have multiple extrathoracic metastases, split into M1C1, where that is a single organ system with multiple extrathoracic metastases, and M1C2, where we have multiple organ systems with multiple extrathoracic metastases.
Thank you. So why don't we dive into a little bit more detail then about the staging categories, and starting obviously with T stage. As you said, there's not been major changes, but perhaps you can take us through some of the clarifications to T staging.
Absolutely. So as you said, the size thresholds have not changed here. For solid lesions and subsolid lesions, the size thresholds are the same as they were in the 8th edition. But then there have been these additional clarifications, which are in red if you're able to see the slides at the moment. T2A is, as previously, if you have a tumor invading the visceral pleura, but also specifically if it's invading an adjacent lobe across fissure, or if it's directly extending if there's a missing fissure. As previously, if the tumor is involving the main bronchus or associated with atelectasis or obstructive pneumonitis extending to the hilum, involving part or all of the lung, that's also T2A. T3, specifically, we now have mentioned in addition to invasion of the parietal pleura or chest wall, that thoracic nerve roots T1 and T2 or stellate ganglion involvement are T3. And then the azygous vein involvement is T3, as well as the pericardium and phrenic nerve. And then separate tumor nodules in the same lobe are T3. Moving on to T4, again, these are additional clarifications in red. So invasion of the vertebra is T4, but also specifically the lamina, spinal canal, subclavian vessels, brachial plexus, or cervical nerve roots. Specifically the thymus, in addition to invasion of the mediastinum, trachea, carina, recurrent laryngeal nerve, also the vagus nerve, specifically esophagus or diaphragm, that's all T4. And then the great vessels have been specified as the aorta, superior and inferior vena cava, intrapericardial vessels, and then specifically invasion of the supraaortic arteries or brachiocephalic veins, a T4. And then, of course, the same as the 8th edition, separate metastatic tumor nodule in a different ipsilateral lobe is also T4.
Thanks, Tanya. So I think that really helps to clarify some of the controversies around T staging. So, for example, a nodule less than 3 centimeters that crosses a fissure is now very clearly labeled as a T2A tumor. So I think some of those T classifications are actually much clearer now, perhaps, than previously. Let's focus now on end staging. So Tanya, this is where the major change is, isn't it, in TNM9? Just take us through that major change.
Yes, that's exactly right. So this is the big change, I would say. N1 is as it was in the 8th edition. We have metastasis in an ipsilateral intrapulmonary peribronchial or hilar lymph node, and that includes direct extension of the tumor. There are no changes to N1, but N2 has been subdivided into N2A and N2B. This is really important. It means that you can have just a single ipsilateral mediastinal or subcarinal lymph node station, and that is N2A. But as soon as you have multiple N2 ipsilateral mediastinal or subcarinal lymph node stations, that is N2B. N3 is the same as it was in the 8th edition. So your contralateral hilar or mediastinal lymph nodes or scalene or supraclavicular lymph nodes would be classified as N3. But I'll show you why we've had this change to our N2 classification. And that is really because they found that when they analyzed this potential change, there is a significant difference in survival for these patients. And that survival difference persists across clinical N2A and N2B separation and pathologic N2A and N2B classification. So this is the graph with the associated paper referenced at the bottom of the slide for those who can see the slides. But you can see that there's a 10% difference in your survival. Your estimated 5-year survival is 10% different depending on whether you have single station N2 disease or you have multi-station N2 disease. So there's some really robust analysis and reasoning behind making this change to the N classification.
Thank you. So a real big difference in survival there, isn't there, between N2A and N2B? So what are the implications then for us in our multidisciplinary team meetings in terms of our clinical staging, perhaps, and our clinical staging pathways?
Yeah, so I think this means that we need to be very mindful and detailed about our nodal classification and staging. It will affect our radiology colleagues and how they're reporting scans. It will also affect any invasive staging that we're doing. And of course, that will include EBUS. that means that we have, I think, an even greater emphasis on systematic nodal staging, which means that we are looking at each station carefully to assess whether we need to sample the station. And then our surgical colleagues, our pathology colleagues also need to be aware of this. But then it all gets brought together and we have a precise way then of describing N2 disease that feeds into an MDT treatment decision. And that treatment decision, of course, could be surgery or radiotherapy, but just really important to be able to distinguish whether our patients are lying in either of these categories.
Thank you very much. So what about M staging? What are the main changes here?
Yeah, so M stage has changed as well. Our M1A and M1B are the same as the 8th edition. So M1A is if you have a separate tumor nodule in contralateral lung, or if you have pleural or pericardial nodules or a malignant pleural or pericardial effusion. M1B remains to be a single extrathoracic metastasis or a single non-regional lymph node. But M1C, has split into M1C1 and M1C2. So this means that if you have multiple extrathoracic metastases in a single organ system, that's M1C1, but if you have multiple organ systems with multiple extrathoracic metastases, then it's M1C2. And just to note here that organ systems can be diffuse. The skeleton is one organ system, so you might have multiple extrathoracic metastases in multiple different bones, but actually that's still classified as M1C1 because it's a single organ system. But there were differences in survival when they tested this change in the descriptor, in the M1C descriptor, and that's why these changes have been proposed in the 9th edition.
Tanya, did the staging committee look at some other M factors? I've always wondered whether the actual number of metastases would affect prognosis significantly, and whether that might at some point be introduced into the staging classification.
Yeah, this is a really interesting point, and it is one that they looked at among actually a few different hypotheses that they had that might change the M classification. So when they looked at the number of metastases that people had, they found that it was more of a continuum. So the more metastases you had, the worse your prognosis was. But when they tried to put a threshold on that number of metastases and tried to then think about incorporating that specifically a threshold into the M stage classification, they found that they were unable to find a threshold. It just gradually increased the more metastases that you had. But also they were a little bit limited by numbers in this analysis. So I think it is something that they will go back to when they're looking at the next edition. An interesting point is that they also looked at the size, the maximum size of a metastasis, to see if that might make a difference and see if they could put a threshold then and incorporate that into the staging. And what they found was that they just didn't quite have enough cases. There were only about 500 with the data that would be required to do that analysis. There was an indication that perhaps a centimetre might be an optimum cutoff, but that's something that's going to be tested, as I said, in the next iteration of TNM with the next data set.
That's very interesting. Thank you. So presumably now we've changed the N staging and M staging, and that's going to have an impact on the stage groupings. So maybe you can talk us through some of the key changes in the stage groupings between TNM8 and TNM9.
Of course. Exactly as you say, we've got an N2A and an N2B now. So of course we do need to consider how that will affect overall stage, and also M1C1 and M1C2. The M1C subdivision is a little bit more straightforward because, as with the 8th edition staging, those are both stage 4B overall. So that's nice and easy to remember. But actually, the changes with N2A and N2B do have some key differences. And really, I think what's reflected here is the importance of N2 and N2A and N2B and how they are affecting your overall stage now quite significantly. So T1N2A is stage 2B, and your T1N2B is overall stage 3A. But T1N1 has now been downstaged to stage 2A. If we have a T2 tumor, then N2A is overall stage 3A, and T2N2B is overall stage 3B. If you have a T3 tumor, N2A is overall stage 3A, and N2B is overall stage 3B. So there are some significant changes there, I think, and it can be a little bit difficult to get your head around. This is something that is available in both the paper that is cited at the bottom of this slide for those who are watching, and also you'll be able to see in the staging manual that the IASLC produce.
Thanks, Tanya. So one other area that we need to cover is residual disease. And this is obviously important in our MDTs when we're looking at post-operative specimens and deciding whether patients may require further treatment. So I think there have been some subtle changes and clarifications here that you can take us through.
Yes, so our residual tumor classification, the R0 means that we don't have any microscopic or macroscopic evidence of residual tumor. Now that is unchanged from the 8th edition. But we have this uncertain residual category, which has both R0 uncertain and R1 uncertain. And there is a clarification in the R0 uncertain, which adds on to a limited node assessment that the highest station lymph node is positive. And when I say highest, I mean closest to the head. And then we have this new clarification of an R1 uncertain category, which includes both carcinoma in situ at the bronchial margin and also pleural lavage malignant cytology that is present or performed in the absence of a pleural effusion. Then if we move on to R1, then that is still microscopic evidence of residual tumor, but there has been a clarification to what extranodal extension sort of counts as, and that is if you have tumor beyond the node capsule, and that's regardless of how the node is resected and regardless of tumor at the node resection margin. You still have malignant pleural or pericardial node syneffusion in the residual tumor classification R1, and you still have macroscopic residual tumor as R2, and Rx is the same. But the reason that they've got this new R1 uncertain sort of category in these clarifications is that they're recognizing a difference in survival in these categories. Even the uncertain category has a poorer survival than your R0.
That's very helpful. Thank you. Should we just sort of turn a little bit perhaps to the future and think about where staging may be going? It strikes me that genomics has to be integrated perhaps in the future. We know that oncogene-driven cancers perhaps have a better prognosis, and that may be reflected in future editions. And what about ctDNA? Where do you think the future of staging lies?
So I think the future is going to be really interesting. The IASLC dataset for the 9th edition, they already started collecting some information on molecular markers, and they've shown that it's feasible to do so, but they didn't quite have the numbers to make any changes to staging at this stage. But in the future, I think we'll have more data to back up potential integration of your molecular markers into TNM staging, and also the involvement of ctDNA. As with all of this, you need enough data to have a robust analysis to then make a proposal to the change in the TNM system. The other thing, of course, is that we've got neoadjuvant treatment and restaging after treatment. So I think that as we get more data on that, it'll be interesting to see how that is incorporated into our TNM staging in the future. And as I've already mentioned, we had those various criteria from the metastatic sort of classification component that will be tested in the future on larger data sets. So I think this could all change significantly, not anytime soon. It's a huge undertaking, but it's going to be really interesting to see what happens in the next iteration.
Thanks very much. Maybe we can summarize some of the key changes again for our listeners.
Yes, so a reminder, the T stage is reassuringly similar. There are some useful clarifications that you can look up in the staging manual, but the size thresholds are the same. And your N categorization is the big change here. You have split N2 into N2A and N2B, and that is whether you have single station N2, N2A, or multi-station N2, which is N2B, and of course that associated overall stage change. M category has also changed, which means that we have M1C split into M1C1 if you have multiple extrathoracic metastases in a single organ system, and M1C2 if you have multiple extrathoracic metastases in multiple organ systems.
And yeah, that's great and super clear. Can I remind everyone that there are lots of resources available on staging on the BTOG website, including these slides for download. And there will also be some reference cards available for you to collect at future BTOG events. Tanya, can I just thank you once again for your really excellent insights into TNM9 for lung cancer. Can I also thank you all for listening? We really hope that we've given you some important information on TNM9 to take back to your MDTs and use in your next meetings. For more information on BTOG, including upcoming education events and how you can join, you can visit www.btog.org.